Ectropion, that is outward turning of the eyelid. It can involve only the medial part without horizontal lid laxicity. Then we do a medial conjunctivoplasty. If it is with horizontal lid laxicity, if it is a mild horizontal lid laxicity, then we do a lacy procedure. If it is severe, then we do a medial canthal tendon plication. If ectropion involves the entire eyelid, if it is without excess skin, then we do a horizontal lid shortening. If it is with excess skin, a Kuhnt Zymanoski procedure is done. First one, medial conjunctivoplasty, which is done when there is no horizontal lid laxicity. Here the punctal ectropion is more pronounced. Medial spindle procedure is performed, means spindle shaped conjunctival and subconjunctival tissue is removed. Here dilate the punctum with a needle shaped dilator at the same time, as this is often stenosed. It is not appropriate to perform destructive procedures on the punctum, as it may resume its normal appearance and function once it has been repositioned against the globe. Here the conjunctiva is lifted just below the inferior punctum. A diamond shaped excision of the conjunctiva is performed using a Westcott scissor. A further cut is made from the opposite side while keeping hold of the conjunctiva with forceps. A diamond shaped tissue defect remains. Broman probe inserted into the inferior canaliculus to protect this during the conjunctival resection. A lacy T procedure is done when there is horizontal lid laxicity if it is mild. Here a wedge resection is positioned to remove the thickened keratinized conjunctiva. It is important that sufficient eyelid is left medial to the resection to enable vertical mattress sutures to be placed across the eyelid margin without risking damage to the punctum or to the inferior canaliculus. A wedge shaped resection is performed just lateral to the position of the medial spindle. The wedge resection closure is performed after the closure of the medial spindle. This is a medial spindle, this is a vertical wedge shape resection. In medial canthal tendon plication is done when there is severe horizontal lid laxicity. It can be a conjunctival approach or a skin approach. Here a conjunctival incision is made between the caruncle and the plica semilunaris. A double-armed 5-0 ethibond suture on a half-circle needle is passed through the medial aspect of the tarsus through the periosteum of the through the medial aspect of the tarsus and through the periosteum of the posterior lacrimal crust. The suture is tied and the medial aspect of the eyelid is repositioned against the globe. In case if the entire eyelid is involved and if it is without excess skin, then we do a horizontal lid shortening, also known as Bick procedure. Here 5 mm from lateral canthus, we make a pentagon incision up to the lower border of tarsus and then we suture it. If there is excess skin, then a modified Kuhnt Zymanoski lateral wedge resection is done. Here a skin flap is raised and a lateral wedge resection is performed. The wedge resection is repaired. The skin muscle flap is drawn laterally and the excess skin and muscles are resected as a base down triangle. The lateral skin wound and the subciliary incision wound are closed with 7-0 Weichel sutures. In next is the lateral tarsal strip. In lateral tarsal strip, indication is usually severe lateral canthal laxity, severe generalized ectropion, and patients who wear ocular prosthesis, as this also deepens the fornix. Here we do a cantholysis with or without the involvement of superior root of lateral tendon. Then a full thickness excision leaving small portion of the tarsus approximately 3 mm is done. A tarsal sling, usually a nylon, below the superior root of the lateral canthal tendon and it is attached to the lateral orbital tubercle. In case of cicatricial ectropion, we do if it is a mild or localized, then we do a set plasty. If it is severe or generalized, then a skin graft or flap is done. In set plasty, we give a set incision. The diagonals here A, C and B, D are drawn at 60 degrees angle to the scar AB. The diagonal line should be the same length as the scar. When the tip F is pulled towards C and tip E is pulled towards the D, the flaps E and F are transposed. Next we do in cicatricial, if it is severe or generalized, we do a skin graft or flap. Here incision is made parallel to the lid margin. Then traction sutures are done to exaggerate the defect, and then we suture it along with bolster. Usually the graft is taken from the upper eyelid, pre or post auricular, supraclavicular and upper inner.